بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, now we are going to discuss one of the most important topics in the thoracic imaging, which is the imaging of the mediastinum. Actually, there are three major topics, in my opinion, in the sector of chest imaging. The first one is about the diffuse lung disease. We have finished about it. The second one is imaging of the mediastinum, and the third one is imaging of the pleura and the chest wall. These are the major topics in thoracic imaging, and this is the second one, and we will proceed in imaging of the mediastinum. I hope in a simple way so that you can easily appreciate the mediastinal lesion and you can reach the differential diagnosis. First of all, you should know that most of the patients having mediastinal pathology are usually asymptomatic, and the mediastinal lesions sometimes are discovered incidentally, and most of the mediastinal lesions are usually of benign nature except for a few of these lesions. And if mediastinal pathology is going to produce a symptom, it will be the sequelae of compression. Compression of the esophagus will result in dysphagia. Compression of the trachea will result in cough. Compression of the recurrent laryngeal nerve will result in hoarseness of voice. Compression of the venous drainage will lead to congested veins. And the compression of the spinal cord will result in some neurological deficits. Then, how to differentiate benign from malignant mediastinal pathology? Actually, we have a general rule which indicates that if you have a lesion which is totally cystic containing fluid, and you may assume its benign nature. However, if you have a solid lesion like this one, for example, you may assume that it may be a malignant lesion. Actually, a benign cystic lesion will show fluid density with no internal septation, no mural nodules, no mural calcification, etc., as we will discuss elsewhere in our topics. Then, as a general rule, we may feel that this lesion is benign from its cystic consistency. However, some of the cysts may be malignant, some of the solid lesions may be benign, as we'll see. Then it's a very important issue is to identify whether this lesion is a mediastinal pathology or a pulmonary parenchymal disease or chest wall, for example. Then how to know that the lesion you are looking at is a mediastinal lesion? Number one, and this is a simple rule, that you can see that the main bulk of the lesion is present in the midline, because you know that most of the mediastinal structures are located in the midline. Then if you see a lesion which is centered in the midline plane, you may assume that this is a mediastinal pathology. Then a second rule is a lesion which is arising from a known mediastinal structure, and you know that the mediastinum contains vessels, the heart, and lymph nodes. Then lymph node pathology is mediastinal pathology. Aortic aneurysm, pulmonary aneurysm, cardiac lesions are mediastinal lesions. Then this is a weak rule, which is that the lesion will form an angle with the mediastinal border, and this angle should be obtuse. And if you look for this lesion, for example, and you want to see the angle between the lesion and the mediastinal border, it's acute. And there is another rule which says that if the lesion is in contact with the mediastinal border for a distance more than 5 centimeters, you may assume that this is a mediastinal lesion. Then look at this lesion which is in contact with the mediastinal border for a long distance, while the angle of the lesion with the mediastinal border above and below is acute. Then this is a diagram to show you what do we mean by a pulmonary lesion and a mediastinal pathology. And this is a pulmonary lesion forming an acute angle with the mediastinal border, which is indicated by the yellow color. While this is a mediastinal pathology which will form an obtuse angle with the adjacent mediastinal border, and you can see this clearly in the diagram. Then, what is the role of the plain film? What is the role of CT? And what is the role of MRI? And also, there is a good rule for diagnostic ultrasound in evaluation of mediastinal lesions. First of all, you should know that the plain film has a weak diagnostic capability in evaluation of most of the mediastinal pathology. And actually, it's good for evaluation of lymphadenopathy, particularly the hilar lymph nodes, and maybe some of the neurogenic tumors, maybe, but it is a general rule that the plain film has a weak contribution for mediastinal evaluation. Then CT is able to detect masses even if they are not seen on the chest X-ray because they are hidden behind the cardiac border, for example, or masked by the shadow of the spine. Then CT is able to differentiate cystic from solid masses by indicating the CT density. Then CT is able to identify calcium within the lesion, which is very important diagnostic issue to separate some of the known lesions which contain calcium. Also, CT, especially CT angiography, is able to diagnose vascular lesions like aneurysms, arteriovenous malformations, and so on. And CT detects invasion of the adjacent organs, like invasion of the superior vena cava, for example, by invasive thymoma, as an example. Then the role of MRI, we can resort to MRI whenever the CT is equivocal, and also CT, in order to show the vessels, you should inject contrast media, but MRI can show the vessels by the known signal void phenomena, and you see this is the ascending aorta, and this is the pulmonary artery, and this is the descending aorta, for example. And CT MRI is more valuable than CT in assessment of spinal lesions and spinal cord invasion or compression. Meanwhile, MRI can differentiate cystic from solid lesions by the same rule as CT. Also, this is a good value of MRI. We mentioned it in the lecture of imaging of lung cancer. That is, whenever you have a lesion which is obstructing the bronchus, a tumor, bronchogenic carcinoma, obstructing the bronchus, and you got consolidation collapse distal to the site of obstruction. Then CT is not able to discriminate the tumor from the consolidation because almost both has the same density, but MRI, especially in the T2-weighted image, because of the water content difference between the tumor and the consolidation, can clearly discriminate both. Then MRI is also good for evaluation of post-operative changes from local tumor recurrence by giving contrast media and by depending on the signal intensity and so on. Then you should know that MRI is insensitive for detection of calcium, and this is good for CT. CT is very good in detection of calcium. Okay, In order to handle the mediastinal lesions, we should divide the mediastinum into the three compartments. And the first compartment is the anterior one, which is located anterior to the heart and in the major vessels. The posterior compartment is located posteriorly in the prevertebral area, and the middle mediastinum, which contains the heart and the major vascular structures. In each of these three components, we have constant findings and variable findings. Then the constant findings in each mediastinum are: each mediastinum should have a cyst, a hernia, and a group of lymph nodes. Anteriorly, we have cyst, hernia, lymph nodes. Middle mediastinum, cyst, hernia, lymph nodes. Posterior mediastinum, we have cyst, hernia, lymph nodes. Then we start by the mediastinal cysts. And by these cysts, we mean benign cystic lesions in the mediastinum, fulfilling the criteria of benign cysts everywhere in the body. And these criteria are the thin wall, smooth, sharply defined margin, clear water content or clear fluid content, and the absence of calcification, septation, mural nodules, and enhancement. These are the criteria of a simple cyst in the kidney, in the muscle, in the liver, everywhere in the body. But here in the mediastinum, we accept that some cysts can show septations and some cysts can show mural calcification. And the mediastinal cystic lesions comprise about 15 to 20% of all the mediastinal masses. In the anterior mediastinum, the cyst is known as the pleuropericardial cyst, and this cyst is located at a characteristic site, which is the anterior cardiophrenic angle, usually on the right side. Then if you have a lesion like this in this characteristic site, which is the cardiophrenic angle to the right side, then the CTs can show that this is a cystic lesion of water density, but it contains septations, and we accept septations and also calcification in these types of cysts, and we call this the pleuropericardial cyst. This cyst is more common on the right side, but can be seen also on the left side. And this is a good example of a pleuropericardial cyst. And being a mediastinal lesion, you can see compression of the adjacent lung. Then this lesion is seen here in the scanogram of the CT of the chest, and the CT scan shows the cystic lesion with internal septation along the right cardiophrenic angle with compression of the adjacent lung. And this is the small pleuropericardial cyst present in a characteristic location, as you can see here. Then we came to the bronchogenic cyst, which is the cyst of the middle mediastinum. And this cyst commonly occur near the tracheal bifurcation at the site of the carina. Most of these cysts are usually asymptomatic, and they contain clear water density, may show internal septations. As you can see here, this cyst does not show internal septations. Then you see a cystic lesion here, which is near to the site of the carina, and this cyst may extend upward in the superior mediastinum, as you can see, compressing the trachea anteriorly and displacing the vessels away. Being in the midline, you can assume that this is a mediastinal pathology. Then look at this cystic lesion in the chest X-ray. In the chest X-ray, you see an opacity, and this opacity has a sharp lateral border and cannot be seen medially because it merges with the mediastinum, and it has a good contact with the mediastinal border. However, the angle between the lesion and the mediastinum is not that obtuse. Then look at the CT scan and you see a cystic lesion, and this cystic lesion is mostly found in the lung. And anyone can assume that this is a water-containing lesion in the lung, diagnostic of hydatid cyst, as we have mentioned before. But if you look carefully, and you can see this cyst is insinuating itself between the superior vena cava and the ascending aorta. If this is a pulmonary lesion, it would not go in this very tight location. But being a mediastinal lesion, it started here. And whenever it became larger, it goes through the easier way into the adjacent pulmonary, displacing the adjacent pulmonary parenchyma. And this is an example of a bronchogenic cyst. In the lateral, in the chest X-ray, you can see that the lesion is in the lung. And here you can see also that most of the lesion looks like as it is in the lung. But if you look carefully, you see that this lesion has a mediastinal component. It compresses the trachea and the esophagus, displacing the superior vena cava upward. And remember, if this is a pulmonary lesion, it would not go this way. It will enlarge in the original site within the pulmonary parenchyma. Then the same rule applies here. And you see is a posteriorly located cystic lesion, which is mostly seen in the right hemithorax. But if you look carefully, and you see that this cyst is going deep into the posterior mediastinum, even crossing to the opposite side. And in this area, you know that the esophagus and the esophagus vein are located here. And this is the classic appearance of the esophageal duplication cyst, which is the cyst present in the posterior mediastinum. And this is also a cystic lesion which is seen insinuating itself behind the aorta, and this is an esophageal duplication cyst being of mediastinal origin. Then you see here a cystic lesion by CT and by MRI T2 weighted image. It shows clear fluid density, but this cyst is present in the posterior mediastinum near the site of the esophagus and the esophagus vein. Then you assume the possibility of esophageal duplication cyst. Then the cyst of the anterior mediastinum is the pleuropericardial cyst. The cyst of the middle mediastinum is the bronchogenic cyst, and the cyst of the posterior mediastinum is the esophageal duplication cyst. Then we came to the hernia, and the hernia, which is located posteriorly in the posterior mediastinum, is known as the hernia of Bogdalek. And this is an anteriorly located hernia in the anterior mediastinum. You see these bowel loops, and you see the location in the lateral chest X-ray. The lesion is located anteriorly, and also in the CT scan, the lesion is located anteriorly, and you see the gas and fecal matter in the bowel loops. And this is what we call the hernia of Morgagni. While the hernia which is located in the middle mediastinum is the hiatus hernia. And this is a good example of hiatus hernia, which is commonly seen in the exams, and because it's difficult to be appreciated in the frontal X-ray, being hidden behind the heart. And if you look carefully, and you can see an air fluid level, denoting that this hernia is incarcerated and is not going up and down. It is incarcerated, and that's why it contains an air fluid level, which is also clearly seen in the lateral view, and this is the site of the hernia. The hiatus hernia has many types, as you will know, and we'll discuss this in full details whenever we are talking about the gastrointestinal imaging. Then this is a huge hiatus hernia, which is classified as type 4, which contains part of the stomach and other abdominal organs, and mesenteric fat, as you can see here, displacing the cardiac shadow anteriorly. Then you remember the groups of lymph nodes we have mentioned in the lecture of chest CT interpretation, and we'll mention them quickly. These mediastinal lymph nodes are located in 9 groups. The first one is the retrosternal, behind the sternum, also known the internal mammary. The second one is posterior to the superior vena cava, known as the retrocaval and sometimes called right paratracheal. The prevascular lymph nodes are arranged along the arch of the aorta. The aortic window lymph nodes are present between the ascending and descending aorta above the pulmonary artery. The carinal lymph nodes are located anterior or posterior to the carina, and the subcarinal lymph nodes are located between the tracheal divisions, and the hilar lymph nodes are located in the hilum. The zygoesophageal group of lymph nodes are related to the esophagus and the azygos vein, also known as posterior mediastinal lymph nodes. And finally, the circumcardiac lymph nodes are arranged along the pericardium. Many times they are associated with pericardial effusion, and they are usually considered to be pathognomonic for non-Hodgkin lymphoma. Then, as I have mentioned before, that lymphadenopathy is a common mediastinal abnormality. It occurs in any of the mediastinal compartments, anterior, posterior, and middle. And nodes, whenever they are normal, they cannot be detected on imaging, except for this lymph node, which is seen retrocaval, and this is the only lymph node which is allowed to be seen as a normal finding. Consider that the patient has no other complaint and he has no any known illness or malignant lesion, for example. Then most of the lymph node pathology is considered here. Number 1, the lymphoma. Number 2, the metastatic malignancies. Number 3, in the infection, considering TB, fungus, and sarcoid. And finally, lymphoid hyperplasia. And I have mentioned, in order to diagnose lymph nodes by the plain X-ray, you can see that the hilar shadow is enlarged with lobulated or festooned margin. Then to confirm your diagnosis, you should go to the lateral view. If you see a soft tissue density superimposed on the hilum, this is lymphadenopathy. If you don't see soft tissue density superimposed on the hilum, you consider these as vessels. Then lymph nodes are diagnosed by CT and MRI based on the size. And most of the literature consider 1 centimeter is a threshold for the lymph node to be pathological. Then these are more than 1 centimeter, of course, lymph nodes, and this is the appearance of a retrocaval lymph node by MRI T2 weighted image. And you should know that the lymph nodes will show low signal in the T1 and high signal in the T2 depending on the water contact. Then mediastinal lymphadenopathy with necrotic center, and you see marginal enhancement or peripheral enhancement of the lymph node, and you consider inflammation or metastatic disease. Bulky amalgamated lymph nodes are usually diagnostic of lymphoma, like these lymph nodes, which are bulky, homogeneously enhanced with no necrotic centers and no calcium. Then lymph nodes containing calcium, you think of TB, which is common in our country. Sarcoid also can show calcium in the lymph nodes, and some of the pneumoconiosis types which can show also calcified lymph nodes. Calcification is rare in malignant nodes, especially those are coming from chondrosarcoma or osteosarcoma may contain calcium elements. Then whenever you see lymph nodes that are calcified, then you think of inflammation, particularly the TB. And you remember I have mentioned that this is the classic appearance on radiologic on chest X-ray for sarcoid. Then you see an enlargement and symmetrical enlargement of the hilar shadows with lobulated margins suggestive of lymphadenopathy, and the lymphadenopathy are also seen on CT scan. Then, in order to reach the differential diagnosis of mediastinal lymphadenopathy, you start first. You have detected lymph nodes, and the patient is not known to have extrathoracic lesion, is not known to have a primary malignancy, not known to have lymphoma, not known to have sarcoid, for example. Then whenever you see mediastinal lymphadenopathy like this, and you think of one of two, sarcoid and lymphoma. And you remember that the sarcoid lymph nodes are discrete, homogeneous, and may contain calcium, while the lymphoma lymph nodes are usually bulky, amalgamated, homogeneous, and do not contain calcium. And you remember this very good example of sarcoid in the chest, and you see the discrete, homogeneously enhanced lymph nodes associated with infiltrative lung lesions in the form of interstitial opacities as well as pulmonary nodules. Then this appearance is usually suggestive of sarcoid, and you see enlargement of the hilar shadows, bilateral and symmetric. There is also enlargement of the paratracheal lymph nodes. Then you have to have the CT scan to confirm your diagnosis, and you see here the lymph nodes are discrete, they are homogeneous, and may contain calcium. Then you can reach the diagnosis of sarcoid. Meanwhile, if you see lymph nodes like this, which are bulky and amalgamated and do not contain areas of breakdown, and also do not contain areas of calcium, and the vessels are floating within the lymph node mass, then you may consider the possibility of lymphoma. And lymphoma, as I have mentioned, you have bulky amalgamated lymph nodes with the vessels floating inside the lymph node mass usually with no areas of breakdown or calcification. Then if there are lymphadenopathy in the chest and there is a non-thoracic, a non-primary malignancy, or the patient is known to have lymphoma. And you see this female patient, 46 years old, is not known to have a primary malignancy, but the primary malignancy is seen in the scan. And this is a mass in the left breast with ulceration on the skin, diagnostic of breast cancer. Then these lymph nodes, prevascular and retrocaval, are considered metastatic, and also the focal lesions in the liver are considered metastatic deposits. Then this patient is known to have cholangiocarcinoma, and the chest X-ray showed prominence of the hilar shadows with lobulated outline suggestive of lymphadenopathy, and the lateral view showed extra density superimposed on the hilum, diagnostic of lymphadenopathy, and it is of the metastatic type because of the non-primary malignancy. Then here, this patient is known to have small cell lung cancer, which is located in the right hilum. And you have seen lymph nodes along the arch of the aorta, prevascular, lymph nodes retrocaval, lymph nodes precarinal, lymph nodes zygoesophageal, and subcarinal as well. Then whenever you know the primary malignancy, or you see the primary malignancy in the images, and you consider the lymph nodes as metastatic, one may say that you have said that metastatic lymph nodes show necrotic center, and this is not always an imaging finding. Metastatic lymph nodes may be homogeneous, may show necrotic centers, but commonly metastatic lymph nodes, because of the malignancy, they show areas of central breakdown and necrosis. Then how can you know that these lymph nodes are metastatic? Because you see the primary malignancy. Then here you see a peripheral pulmonary nodule with a speculated margin, and you see a lymph node posterior to the superior vena cava, and another lymph node here, or the same lymph node, then you assume that these lymph nodes are metastatic from this primary malignancy. Then we have finished with the constant lesions in the three compartments of the mediastinum, considering that every compartment should have a cyst and a hernia and some group of lymph nodes. And we have discussed the differential diagnosis of mediastinal lymph nodes, considering the inflammatory nature, the metastatic, the lymphomatous, and the sarcoid lymph nodes. Then we came to the specific lesions in each compartment of the mediastinum. And we start by the anterior mediastinum, and we have the three, and sometimes I consider four, the three pathologies which start by the letter T. And number one is the thyroid mass extending into the superior mediastinum, retrosternal extension, the thymic tumor, the teratodermoid tumor, and the fourth one is known as the terrible lymph nodes, which are due to actually lymphoma. Then let us discuss these three issues, starting by the first one, which is the thyroid extending retrosternal. You should know that the only lesion, if I can say that, the only lesion which caused tracheal displacement is the thyroid. Then if you see the soft tissue opacity or a mass in the superior mediastinum, which is displacing the trachea to the opposite side, and you can assume that this is thyroid with retrosternal extension. And to confirm this, you may have a CT scan or ultrasound or a thyroid scan. All these can be better investigations, also MRI as well. Then, and the CT scan, you see the axial image, you see the left thyroid lobe is small, the right one is big, is large. Then you see the sternum, and you see a mass behind the sternum. In the axial image, in the axial images, do not jump to the diagnosis of retrosternal thyroid extension unless you see the sternum and you see a thyroid tissue behind it. Then in the sagittal image, it is easy to see the thyroid and the retrosternal extension, and also in the coronal image you can see that both lobes of the thyroid gland are enlarged. They contain multiple hypodense colloid nodules as well as foci of matrix calcification. Then you see here the thyroid gland, both lobes are enlarged. The left one is more enlarged than the right one, and you don't see the sternum. Then you cannot judge the retrosternal extension unless you see the sternum and you see the thyroid which is behind the sternum. Then you know that there is retrosternal extension. Then in order to discriminate the benign from malignant thyroid masses, usually it's not that easy unless you can see in the scan evidences of malignancy. And these evidences include marked irregularity of the tumor, invasion of the surrounding structures, and the presence of metastatic lymphadenopathy in the neck. And here you can see, and this is anaplastic thyroid carcinoma which has invaded the larynx. And you see that the thyroid cartilage is destroyed and the tumor is extending inside the larynx itself. Then this is one of the criteria of malignancy, and also if you see metastatic lymphadenopathy. Then we came to the thymus, and the normal thymus early in the first year of life, it will show convex outer margin like this. This is the normal appearance of the thymus. After the age of 1 year, you will see the characteristic sail sign, and this is very pathognomonic to a normal appearance of the thymus in children older than 1 year. Then on the CT scan in the pediatric age group up to 2 or even 8 years in age, you can see the thymic tissue along the anterior aspect of the arch of the aorta, between the arch of the aorta and the sternum. But in the adult population, the thymus has regressed, and you see only the fat in the anterior mediastinum. Then A mass located in the anterior mediastinum at the site of the thymus between the arch of the aorta and the sternum is supposed to be a thymic tumor, which is most likely a thymoma. And the thymoma is seen between the ages of 40 and 60 years of age, and with equal distribution between males and females. These lesions arise from the thymic epithelium, and we have 1/3 of these lesions showing malignant criteria with invasion of the adjacent mediastinal structures, and about 35% of patients with thymoma may have myasthenia gravis, and about 15% of patients with myasthenia gravis have thymoma detected on imaging. Then this is a very important criteria, is that you cannot discriminate between benign and invasive lesions of the thymus, even histologically. And we usually say the malignancy or the invasiveness of the lesion based on invasion of the adjacent structures. Then look at this chest X-ray and you see a lesion here along the right mediastinal border. In the lateral view, you see that the lesion is projected anteriorly, meaning that it is in the anterior mediastinum. Then if you have the CT scan and you can see a mass which is between the arch of the aorta and the sternum, and that the mass is solid, it may show necrotic center and is located in a characteristic location, then you can say that this is thymoma. And here is an example. You see the lesion, you see the mass in the CT scan, and you see here the mass is solid. And it's very important that this mass is compressing and displacing the arch of the aorta and the superior vena cava. Sometimes thymoma may give lymphoma, or what we call thymic lymphoma. And thymic lymphoma as also the lymphoma arising from the anterior mediastinal lymph nodes will show the floating vessel sign. The vessels are not compressed, the vessels are floating inside the mass, and this may be helpful to discriminate between thymoma and thymic lymphoma. Then you see here a mass and you see a tumor tissue within the superior vena cava, then you call this invasive thymoma because it has invaded the superior vena cava. Then this is considered one of the malignant features: invasion of the vessels, invasion of the airways, involvement of the lung or the chest wall or the cardiac shadow, spread along the pleura into the abdomen. All these criteria are supportive of the diagnosis of invasion. And here in the chest X-ray, you can see there is lobulation of the mediastinal border, suggestive, for example, of lymphadenopathy. Then the CT scan showed that there is a mass at the characteristic site of the thymus, and this mass has extended into the superior vena cava, diagnostic of invasive thymoma. And here is also a mass which is located along the mediastinal border on the right side, and the CT scan showed the presence of a mass with invasion of the superior vena cava. The superior vena cava is totally obliterated, and also extension of the tumor into the right atrium. This is the right atrium and this is the left atrium, as you remember. And this, both in the X-ray and in the CT scan, you can see some pleural fluid bilaterally here and there. Then anterior mediastinal lymphoma may arise from the thymus, what we call thymic lymphoma, or from the anterior mediastinal lymph nodes, considering the retrosternal lymph nodes. And one of the signs of lymphoma is the floating vessel sign, and you can see the vessels are floating undisturbed within the lymphomatous mass, and the mass is made of bulky amalgamated lymph nodes without areas of necrosis or calcification. And then if you look here, and you can hardly see a change in the frontal chest X-ray because you don't see the contour of the arch of the aorta and the pulmonary artery. And if you look carefully here, and you can see a shadow of a mass in the anterior mediastinum. Then on the CT scan, and you can see a mass in the characteristic site of thymic gland, and you may assume that this is thymoma or thymic lymphoma. Then after biopsy, and most of these lesions are usually biopsied by imaging guidance, then it has proved to be a Hodgkin lymphoma. Then we came to the third lesion, which is the teratodermoid, and this teratodermoid is diagnosed by the presence of fat and calcium and cystic changes. And actually, if you see fat, this is enough. If you see fat and calcium, this is good. If you see fat, calcium, and cystic changes, this may confirm the diagnosis of a teratodermoid cyst. And one of the criteria of the teratodermoid cyst in the plain X-ray is that it bulges on both sides of the mediastinum. Maybe on one side more than the opposite side, but usually the lesion is centered to the mediastinum with bulge on the left and bulge on the right. One may say that why I don't consider these as lymph nodes. I say that because of the smooth margin of the lesion. And in the lateral view, the lesion is projected anteriorly. It is not projected on the region of the hilum. Then by the plain X-ray, you cannot detect calcium, you cannot detect fat, you cannot detect the cystic changes, and you need the help of CT. Then this is the lesion which is located in the anterior mediastinum, and you see the fat which is hypodense more than fluid, and you see also calcium. Whenever you see fat and the calcium, this is enough for the diagnosis of teratodermoid cyst. Then here you see a mass in the left side of the hemithorax. Then the CT scan showed that the mass is mostly cystic, and this is fluid, and it contains calcium and traces of fat. Then you reach the diagnosis of teratodermoid cyst or teratoma. And in this patient, you see a mass which is mostly cystic, and you see the fat, and you see calcium. And here are the three components for the diagnosis of the teratodermoid cyst. If you look here, you can see this lesion, and this is not the arch of the aorta, and this is not the pulmonary artery. In the lateral view, you can see the lesion, and you may feel the presence of calcium. Then in the CT scan, you see the lesion in the anterior mediastinum, and you see the calcium, and you see the fat which is surrounding the calcium. Also here you see a very big mass, and this mass contains fat and it contains calcium as well. One may say that why I don't consider this as a pulmonary parenchymal mass, and this is an adult patient, and the bronchogenic carcinoma is most likely, and you have said that bronchogenic carcinoma contains calcium. I say yes, but I didn't say that bronchogenic carcinoma contains fat. And this is very important in the differentiation between masses in the mediastinum and the masses in the lung. And here is the scans of mediastinal teratoma showing calcium, fat, and some other soft tissue densities. Then we finish with the anterior mediastinum, and we came to the middle mediastinum, and most of the middle mediastinum lesions are of vascular origin, considering the aortic aneurysm and the pulmonary aneurysm, and of course the presence of mediastinal lymphadenopathy. And we have taught whenever we are young that whenever you see a mass like this and you can follow the contour of the aorta, you are sure that this mass is not arising from the aorta. But if you see a lesion like this and you try to follow the aorta through the lesion, you cannot, then you assume that this is of aortic origin. And this lesion is located exactly at the region of the aortic knuckle or knob. Then in order to look for the aortic knob you cannot see, then you assume that this lesion is of aortic origin. And the CT scan showed that is an aneurysm arising from the arch of the aorta, and this hypodensity represents mural thrombus, and this linear hypodensity represents an intimal flap, which means that this aneurysm is of the dissecting type. Then this is the ascending aorta, which is hugely dilated, It does not contain mural thrombosis nor intimal flaps, and this is just a saccular aneurysm of the ascending aorta. Then here you see that the shadow of the aorta is markedly dilated and tortuous going across the mediastinum. And this has been confirmed by CT. This is the descending aorta, which is aneurysmally dilated with a linear intimal flap inside, meaning that this is dissecting aortic aneurysm. And this is the rest of the aorta, which is going across the mediastinum, showing mural hypodensity representing thrombosis, as well as linear hypodensity representing the dissecting intimal flap. The reconstructed images of multi-detector CT are extremely helpful in the detection of the type of dissection, whether it affects the ascending only, or the arch and ascending, or the whole aorta, and you can follow the dissecting intimal flap until you reach the iliac vessels. And this is the pulmonary artery aneurysm. And if you look here, this is the main pulmonary artery, this is the ascending aorta, and this is the superior vena cava. Then this is the left branch of the pulmonary artery, and this is the right branch. The left branch is aneurysmally dilated, and a mural thrombus, large mural thrombus, is seen inside. And you know, most of the pulmonary aneurysms are usually related to Behçet disease. I will discuss this in details whenever we are talking about the imaging of the pulmonary vascular lesions. Then in the posterior mediastinum, we have three major lesions: the neurogenic tumor, esophageal lesions, and the spinal pathology. The spinal pathology will also be discussed in full details in the sector of the spine imaging. This is a good sector containing a lot of lectures. Then we'll talk about neurogenic tumor and tumors and esophageal lesion. We have too many neurogenic tumors encountered in the posterior mediastinum, and you cannot actually know the histologic type of each of them from the imaging, but you may only suggest that this is a neurogenic tumor. Then neurogenic tumor is located in the posterior mediastinum, usually in the paravertebral gutter. Sometimes, whenever this tumor has a component inside the spinal canal, what we call the dumbbell configuration, it facilitates the diagnosis. But if the tumor is like this, and it usually simulates a mass in the lung, and a mass in the lung is considered as bronchogenic carcinoma. But one of the helpful criteria is that the neurogenic tumor is a benign lesion, especially in adults, and the benign lesion has a smooth outline. But the bronchogenic carcinoma has an infiltrative character, and it has an irregular margin. Also, the presence of calcium in the bronchogenic carcinoma is more than the presence of calcium in the neurogenic tumors, especially those found in adult population. But you know that neuroblastoma, for example, which is seen in the pediatric age group, 85% of these tumors contain calcium. Then you see here a lesion which is masking the shadow of the aorta and the pulmonary artery, and this lesion is projected posteriorly in the mediastinum. Then here by MRI T2 weighted image, and you see that the lesion is located in the paravertebral gutter with an intraspinal component, being a pediatric age group, and you consider the possibility of neuroblastoma. Then this is another case of neuroblastoma in a female child, 2 years old. The neuroblastoma showed a mass along the mediastinal border. The CT scan showed the presence of calcium and the extension of the mass inside the spinal canal. And actually, the most common mass encountered in this pediatric age group is usually the neuroblastoma. Then in adult population, the neuroblastoma may mature into the more benign form, which is known as the ganglioneuroma, and this is a large posterior mediastinal mass, because you have the lesion in the mediastinum crossing to the opposite side, and you have another component here, and you can see calcium in the lesion as well. And this is a posterior mediastinal, a posteriorly located lesion from the frontal X-ray. You know the silhouette sign, and this is the cardiac border, which is clearly identified through the mass, meaning that the mass is located posteriorly. Then in the lateral view, the mass is located posteriorly, and in the chest X-ray, in the chest CT, the mass is also seen posteriorly, and this has been proved after biopsy to be a schwannoma. Then esophageal lesions are easy to be diagnosed because of the symptoms and because of the characteristic location and the appearance. Actually, you see the mass is in the anatomic site of the esophagus, and you can see residual esophageal lumen within the mass, and you can also give the patient some oral contrast to confirm that the lesion is arising from the esophagus. And most of the esophageal lesions are of the malignant type, the esophageal carcinoma, but some of these lesions may be of the benign nature, like leiomyoma of the esophagus, for example. And this is a case of esophageal carcinoma in a male patient, 63 years old, and you see the mass at the anatomic site of the esophagus. We have given the patient oral contrast, and you can see the area affected from here down to there. And you see the extremely narrowed irregular esophageal lumen with a large posterior mediastinal mass centered to the esophagus. And this is also a case of cancer esophagus centered to the anatomic site of the esophagus, associated with bilateral pleural effusion and metastatic pulmonary deposits. And in this lesion, which is intimately related to the esophagus is stretched over the lateral border of the lesion. And we have given this patient some oral contrast, and you see air and oral contrast. And this is classic for esophageal leiomyoma, which is arising from the esophageal wall and grow outside the esophageal lumen, as you all know. And here is just an example for spinal TB, with a huge prevertebral abscess filling most of the posterior mediastinal space. And this is also an example of huge tuberculous abscess with air fluid level in the posterior mediastinum, posterior to the trachea and posterior to the esophagus, with also abscesses in the chest wall muscles. Then finally we came to the lesions which can be mistaken for a bronchogenic carcinoma, and they are actually of mediastinal pathology. Then these lesions are only two: the thymic tumors and the neurogenic tumors. If you look to this chest X-ray and you see a mass here along the mediastinal border on the right side, the CT scan of the lesion showed that there is a mass with mediastinal lymphadenopathy posterior to the superior vena cava. If you want to diagnose this mass, you may say that this is a bronchogenic carcinoma with metastatic lymphadenopathy and a pleural effusion. One may say that no, this is a thymic tumor with lymphadenopathy and effusion. I say, well, how to reach the final diagnosis is by biopsy. And most of the cases of thymic lesions or the suspected lesions as bronchogenic carcinoma should be biopsied to confirm the diagnosis and to know the cell type and to stage the tumor. Then you see a lesion here, and this lesion by CT, and you can see a mass. And if you say that this is a bronchogenic carcinoma invading the mediastinum, this is a good diagnosis. On the other hand, you may say that no, this is a mediastinal lesion that has grown into the adjacent lung parenchyma. I say, well, which part of the mediastinum where this lesion is located? You will say that this is the middle mediastinum. I say that no masses in the middle mediastinum. Most of the middle mediastinal lesions are vascular in origin or lymph node in origin. Then we shall go into the final step, which is to take a biopsy from this lesion, and it has been proved to be a bronchogenic carcinoma. The previous one also has been proved to be a bronchogenic carcinoma. Actually, fatty lesions in the mediastinum cannot be diagnosed by the plain X-ray because you see fat as opacity similar to any solid mass. But here in the CT scan, you can see fat with characteristic hypodensity similar to the axillary fat and to the subcutaneous fat. And actually, there is no need to have an MRI with fat suppression technique in order to confirm your diagnosis, because the diagnosis in most of the cases is usually evident. You should accept some of the fat in the mediastinum, especially the anterior one, and also in obese patients. But whenever the fat is a little bit prominent, you may say that this is mediastinal lipomatosis, which is a benign lesion doing no harm for the patient. And I thank you very much.